And now, today is another discussion about complications of diabetes. And of late, from the statistics, is that so many patients who have diabetes have started developing dementia, which is going undiagnosed in so many clinical setups. And so today is very important to look at this one of the complications, which is silently coming up because of insufficient blood supply to the brain, either in diabetic patient or in a hypertensive patient. Because most of these patients are manifesting with features like Alzheimer, and also you know very well that it is a little bit difficult for us to cut a straight line in between Alzheimer and the avascular and dementia. So our topic today is about avascular dementia. Briefly on how to discuss on how it comes about, on how to handle those type of patients and the expectations, so that you can build a good knowledge in this in various practitioners around this type of client. So avascular dementia is classified as a neurological problem, which is like a syndrome of chronic progressive cognitive decline resulting from functional impairment of the brain. So as per the Manual of Mental Disorder, 5th edition, it defines that as a cognitive decline in quantitative deficit in one or more domains. For example, this person can have a problem of decline in memory, decline in executive functions, or decline in visual spatial, or also language and attention. So in case one person has a decline in this one, then that is what about to be about dementia. They know very well, so many practitioners will realize that so many people are having this type of problems, especially patients with diabetes, patients with hypertension, especially at the age of 60 and above. Now, second only to Alzheimer's disease, vascular dementia is one of the most common cause of dementia affecting the elderly in the age of 65, and with the variable presentation that we have seen there. And this disease is progressively slowly and very difficult to predict the progression of which direction is going to take. So the diagnosis of vascular dementia is thoroughly on clinical basis and physical examinations. Though, so the experience and the knowledge of the clinicians who is seeing this patient is the one which is going to know whether this person can have a high index of dementia. So vascular dementia is diagnostically challenging and does not have places given a cause of dementia, including potential from a mixed dementia syndrome, because dementia can even occur because of old age, dementia can occur because of brain atrophy, can occur because of injuries. All these type of things can cause dementia. So how are you going to tell that this avascular dementia is associated with diabetes? How this avascular dementia is associated with hypertension? So let us look at causes. So vascular dementia is distinguished from other forms of dementia in that it is thought from the brain ischemia, insufficient blood, the brain resulting to cellular changes in the brain. Although the temporal relationship between the ischemia event may be subtle or go unnoticed in some cases. So there are various subtypes and multiple terms to describe the vascular pathology and affect brain tissues, just as multiple infarct dementia, small vessel disease, or also Binswanger disease, stratifying infarct dementia, hyperperfusion dementia, hemorrhagic dementia, hereditary vascular dementia, or even Alzheimer disease with cardiovascular disease. All these ones are some of them subtype and terms which are used to describe this type of disease. So epidemiologically, 15% to 17% of all dementia syndrome are vascular in etiological. So it's a big number in the population. So the incidence of vascular dementia increases with age, with the risk of doubling approximately after 5 years. Risk factors for the developing of vascular dementia include either the patient is having hyperlipidemia, hypertension, diabetes mellitus, or also a history of tobacco use. So the pathophysiology of this vascular dementia is that it occurs as a result of cerebral tissue ischemia, causing gliosis and demyelination of the cells. And ischemia may occur as a result of atherosclerosis in the blood vessels of the brain, or as an emboli, or even an vasculopathy. This one compromises the blood supply to that part of the brain, so there is no diffusion in between the brain barrier. So there are several subtypes of vascular dementia, including the following. For example, there is also something called Binswanger disease. Sometimes it's called a syndrome. Also, there is mirrored vascular cognitive impairment. There is mixed dementia, which is a combination of vascular dementia plus Alzheimer, where there is a discussion about diabetic type 4. Sometimes people call it diabetic type 4, since it has been started being discussed as a diabetic type 4 since the year 2015. So there is another one called multi-infarct dementia. There is corticovascular dementia. There is vascular dementia due to arcuate single infarct, and also vascular dementia due to lacunar lesions, and vascular dementia due to hemorrhagic lesions. Diagnosis. How do you diagnose this disease? So diagnosis of vascular dementia allows a physician to provide a patient and the caregiver with variable counseling and regarding secondary prevention, safety advice, care planning, and caregiver burden. Secondary prevention discussion may focus on healthy diet, exercise, cognitive stimulation, and socialization. As a healthcare provider, our goal is to ensure safety with optimal independence. So their diagnosis purely based on clinical suspects is based on clinical examination and also cognitive measure performance is the way we diagnose this type of condition. So in this case, you have to see your patient for quite some time, even if it can go all the way to 1 year by the time we realize some of these minute stages are in the early stages. Let us look at treatment. Treatment of vascular dementia include two approaches. Number one, it has to depend on management of progression. You have to manage this disease from progressing, and also behavior, and also to prevent by modifying risk factors. So you work on preventing this disease from progressing in terms of the behavior and the disease, and also prevent the modifying factors like blood pressure, diabetes, hyperlipidemia, tobacco use, all those ones. You have to focus on them. So cholinesterase inhibitors have been shown to slow the progression of cognitive decline. The side effect profile is significant, including gastrointestinal distress, symptomatic bradycardia, and agitations as the side effect of these drugs. So also these ones, they have to be very careful about them. You have to monitor the side effect of these drugs. So Menatone and NMDA antagonist is food and drug agency approved for moderate to severe dementia, has been shown to improve the patient functions levels and lessen care dependence. So that's another drug which has been approved for use for this type of crimes. Now, whether to offer these medications takes a careful conversation with the patient and the caregivers, weighing the benefit and side effects individualized to their health conditions and goal. There should be a proper discussion, a proper understanding between the two, so that you can achieve a therapeutic goal for this patient because they want to use these drugs. So issue of driving medications, management, financial management, and the cooking are some of the issues that comes out when you are evaluating these things, because the people have to know their social life are part of them. So in advanced care planning should explore patient value as the interventions, quality of life, longevity. Lastly, provide a caregiver in support and education, which may consist of support groups or respite care to manage caregiver burden. Now, out of that one, now you have seen this condition called avascular dementia. Out of this one, now let us look at a few case studies. Now, we have a patient who is 75 years age, female, and has a 12-year history of progressive decline of cognitive function. A family note that every few months, there is a marked change in functions, She has a poor short-term memory and is brilliant. She has a history of coronary artery disease with stent, hypertension, and hyperlipidemia. The exam shows poor memory and attention in mid-right hemiparesis, bilateral Bicking's reflexes, and Bliski reflexes bilaterally. So select the best intervention to prevent further decline. You see these patients, 76, that means it's more than 65 years of age, 12 years of progressive decline in cognitive functions. There is marked changes. There's a poor short memory, Virgin, she has a history of coronary artery diseases, now a cardiovascular disease, the stent, but she has a hyperlipidemia. Those are factors which can be modified, and there's a poor memory attention with the right and paralysis, with the blood, with the bilateral bump reflexes and brisk reflexes bilaterally. So the right answer there is improved hypertension control is very important, because these are factors which can be controlled, which can be adjusted so that you can be able to control dementia. Because if the pressure is very high, still you don't get a good what? A good result in this type of patient. Now, let us see the teaching point about this one. No, the stepwise decline in function and history of vascular disease makes the vascular dementia the most likely diagnosis because of stepwise function and history of vascular disease, which is coronary artery disease. Improved blood pressure control may prevent further stroke, and the citalopram is used for anxiety and depression and sometimes for behavior and psychological, so it is not the best drug. So symptoms of dementia, but will not prevent recurrent stroke from occurring. So VP something is used for normal pressure and roqueferas and the psychotherapy for syndrome dementia. So in this case, the correct answer is improved hypertension control because of that discussion there. Because improved blood pressure control may prevent stroke in this case, because blood pressure is the only factor which you can control there. Now, let us look at case study number 2. In this case study number 2 is that we have a patient with severe long-term hypertension, present with worsening dementia. MRI is done on the brain and shows diffusely declined in T1 signal of the deep white matter. Given the record diagnosis, which of the following best describe the pathology of this patient's condition? Number 1, subcortical leukoencephalopathy, neurofibrillary tangles, low blood body deposit, proteinous inclusion bodies. The right answer is neurofibrillary tangles. Now, let's see the reason why we have seen this answer. So, the subcortical leukoencephalopathy is also known as Binswanger disease, a subtype of vascular dementia. It is associated with chronic hypertension. It is different from hypertension encephalopathy, which by definition is due to malignant hypertension. In Binswanger disease, there is an irregular diffuse loss of myelin and axons. Neurofibrillary tangle are seen with Alzheimer's disease. Proteinous inclusion bodies are found in Huntington diseases. Then bodies are seen in Lerin body and dementia. So that is the discussion about that condition. And I think that's a very good discussion about avascular dementia. We have seen the causes, how it looks like, the clinical, the outcome. All these ones are there for us. Thank you very much for listening to this one, and I hope this one will be able to assist you to manage these conditions. Thank you very much.